Hi, everyone. I'm really excited that we are meeting together. I am Sydney McKinney, the Executive Director of the National Black Women's Justice Institute. As people are entering the virtual room, I love knowing who is with us. So please share your name and where you're from in the chat. I like to call out folks a little bit, and then we'll give it a few seconds, let people enter, and then we'll get started. Before we jump in, I want to let people know that closed captions are available. To access them, you're going to go to the button on the bottom of your screen that says Live CC. You're going to click on that, and you're going to have a few options to select from. If you have any difficulty, you can always chat the person named NBWJI who can help you with any tech issues you have along the way. So I can't see the chat for some reason. Oh, there it is. So we have Kathy Wyatt. Oh, hi. Megan Comfort, Jennifer Avery. This is very exciting. Medina from our team is here. We have Rose Ashford, Ebony Curry, Washtenaw, as in like Washtenaw, Michigan. We've got a lot of folks joining us. This is so exciting. Okay. So I am so happy to have each and every one of you here with us today for a conversation about supporting the health and wellness of Black women who have experienced incarceration. In 2022, we launched the Pathways to Wellness study, a groundbreaking research study exploring the needs, experiences, and health-seeking behaviors of Black women who have experienced incarceration. Like all of our projects, this study is inspired by innovation led by directly impacted Black women. We started this research knowing full well that incarceration negatively impacts health. Black women in particular face persistent health inequities inside and outside of prison. Chronic diseases, co-occurring conditions, and trauma are all too common. But what we didn't know was, what are formerly incarcerated Black women's primary health concerns? Where do physical health and mental health rank compared to all of the other issues and concerns they must address when they come home? How do Black women's medical experiences during confinement impact their healthcare decisions when they come home to the community? These are all critical questions that we sought to answer so we could begin to find solutions that eliminate the deep health inequities facing Black women who have experienced incarceration. I am so grateful for the candor and vulnerability and the trust of the women who participated in this study. They courageously shared their stories with us. Regrettably, most of their experiences were negative, and in many instances, the medical services they received while incarcerated worsened existing health conditions or caused additional emotional and physical harm. But I'm also so happy to say that we heard tremendous stories about soul care, healing, collective advocacy, and hope. I'm also so grateful to each of you who is here with us for this collective conversation we're about to have so that we can use the research that NBWJI did to develop collectively a system of care that enhances and increases directly impacted Black women's and girls' access to gender-responsive, trauma-sensitive medical and mental health care. With that, I'm excited to pass things along to my colleague, Dr. Janaé Bonsu-Love, who is the Director of Research and Advocacy and really led this study.
Thank you, Sydney, and thank you everyone for joining us today. I'm really excited to talk about this research and really be in conversation with our dynamic panelists today. Sydney gave a great overview of why we did this study, and I just want to add just a few key findings or really want to add some things about our approach along with some key findings and themes before I bring on our panelists today. So NBWI conducted this qualitative research study to really better understand the health needs of Black women as they return to their communities from incarceration, in order to really begin to help healthcare providers and other stakeholders in reentry better understand and meet the health needs of formerly incarcerated Black women, and ultimately expand the landscape of reentry programs and policies that are attentive and responsive to this important intersection of race, gender, health, and incarceration. And so we approach this study through a Black feminist framework, which at its core means that we committed to the principles of one, using an intersectional lens to explore how race, gender, sexuality, age, place, disability interacted to shape the reentry experiences of formerly incarcerated women in their health. We also focused on strengths instead of deficits in views of Black women as problems to be fixed. We focused on cultural affirmation, or really ensuring that all aspects of the research were culturally affirming and relevant, especially in our interview guide and the way that we approached our questions. Dialogue and self-definition was also an important principle in how we approached the study, really creating space throughout the research process for women to speak for themselves and define issues that were important to them. Also being reflexive in this process on the part of the researchers, committing to ongoing self-reflection about the impact of our own personal experiences and assumptions as researchers on the process. And lastly, but most importantly, principle and commitment to community care, really ensuring that the research advances the well-being and goals and priorities of directly impacted Black women. And so to that end, we convened an advisory committee of directly impacted women who've experienced reentry themselves and are at the helm of organizations that serve and organize to help other women successfully do the same, to help steer and develop the implementation of the research study, and ultimately help hold the research team accountable to these principles and overall goals of the study. And so through semi-structured yet conversational interviews with 21 Black women with incarceration experience in the state of California, we sought to understand, as Sydney mentioned, their health concerns, how they prioritize their wellness needs, how they access care, and identify barriers to care. And importantly, we also sought to understand their desires from the systems that they have to navigate for their wellness and their self-care practices and healing journeys. And so several key themes and findings emerged from our interviews with the women in the study about their health and wellness needs both during and after incarceration. One being that incarceration negatively impacts their health and exacerbates already existing health needs. And this is aligned with previous research showing the negative and exacerbating effects of incarceration on health. And the women in this study in particular detailed experiences of inadequate and neglectful care, which they described as resulting from racial and gender bias, stigma related to drug use and their conviction histories, and stereotypes and perceptions that Black women don't feel pain and are manipulative, and other harmful stereotypes, biases, and stigmas that resulted in treatment delays or long waiting periods to be seen by healthcare providers. And when they did see a healthcare provider while incarcerated and received a diagnosis, there being a lack of follow-up and misdiagnoses, all of which worsened health outcomes. Another key theme or area that emerged was that health concerns competed with many other needs after incarceration, but high priority health concerns included certain chronic conditions, which were underscored by aging, reproductive health needs, obesity and weight gain, and behavioral health. One important thing I want to underscore about the chronic health conditions is that more than 75% or 3 in 4 of the women in our study reported having a chronic health condition. Nearly 1 in 4 of the women in the study were at least 50 years old at the time of their latest release from incarceration. And 38% of the women in the study were lifers for serving life sentences or indeterminate sentences up to life in prison. So having served 15, 25, 35 plus years in prison, of course, they're aging, and the carceral environment itself tends to accelerate aging. So they're experiencing and coming home with issues related to uh, diabetes, not hypertension, high cholesterol, starting menopause while incarcerated and not having the support or even full knowledge of what's going on with their bodies. Um, and as far as behavioral health, one thing that I want to note is that 2/3 of the women in the study reported having a mental illness or substance use disorder or both, which they directly connected to traumatic experiences before incarceration and the exacerbating effect of the carceral environment itself. And while some really sought to uh, get mental health and medical care provision after incarceration, there were some who expressed concerns and fear and hesitation around uh, professional mental health care, excuse me, specifically due to fear of being diagnosed or labeled if they started receiving mental health services and the potential negative impact of certain diagnoses or labels on other important reentry goals, like reuniting with children, with minor children. Kind of third theme or area uh, that was important in our findings is that accessing healthcare is difficult after incarceration due to internal and external barriers. One internal barrier being distrust of healthcare or the healthcare system due to the negative experiences with carceral care that I previously mentioned around stigmatizing labels of being criminal, being Black, being a woman, and women not being willing to subject themselves to potentially unfair treatment. Um, but other factors around the lack of or limited pre-release planning and coordination hindered women's ability to access healthcare, as well as having a lack of understanding of how insurance works, what it covers, what it doesn't. Um, those things really had an impact on the ability to make well-informed decisions about their healthcare and access to the health services that they need. And lastly, around place, the importance of place, inequities in access to quality health services, healthy food, and opportunities varied by geographic location. So where women were released or paroled played a role in their ability to access healthcare. Uh, but despite these barriers to healthcare access, women developed their own strategies to address their health needs after incarceration. So Black women with incarceration experience engaged in self-care that supported their holistic wellness in a number of ways, including what one participant called soul care, which is the spiritual beliefs and practices that act as sources of strength and resilience and grounding. Also, self-advocacy was a key strategy for addressing their health needs, both during incarceration and after. So during incarceration, many participants filed administrative grievances to get proper medical care. After incarceration, many women advocated for themselves by speaking up to ensure the best possible health outcomes, whether it's explaining to a doctor due to addiction history that certain pain medication shouldn't be prescribed, or advocating around a medical charge that was a mistake, or that wasn't clearly articulated. And in a similar vein, collective care was just as important. And this is the connectedness, emotional and mental support from sources like pastors, church circles, support group meetings like AA and NA, but also advocating for and serving others was healing. More than half of the women in the study work for or volunteer in direct services and or advocacy organizations, and they view that labor of love as part of their healing and post-traumatic growth. And connecting with supportive organizations is also a part of that. After release from incarceration, the ability to connect with supportive organizations was critical in accessing various resources and services to support their health. And lastly, and importantly, desires for health and wellness included access to wraparound support services, particularly peer support, safe, affordable housing, accessible information, and diverse, competent, and passionate providers. Women in the study named factors like attentiveness, respecting boundaries, and taking the time to educate as what's characterized positive provider experiences for them in the past and what they want to see more of from healthcare providers moving forward. And so, taken together, the experiences shared and themes that emerged from the research offers insights and imperatives for mitigating and interrupting the harmful effects of this interplay of racial bias and gender discrimination in incarceration history on formerly incarcerated Black women's health and wellness. And today I want to talk about what those implications are with our panelists. And so I'm going to introduce them to join me in the spotlight here. So first joining us today, we have Dr. Marilyn Jones, who is the founder and executive director of Because Black is Still Beautiful, a nonprofit organization that is committed to building pathways to liberation for Black women and girls. She has a great deal of experience, conducting academic and professional research on formerly incarcerated men and women, as well as teaching this population. Dr. Jones holds a BS in health education, MA in adult education, and an EDD in educational leadership. Dr. Jones is the creator of the Araminta approach, a culturally affirming framework specifically designed to improve outcomes in the lives of Black women with histories of incarceration. She provides trainings, staff coaching, and curricular development, utilizing the approach to create a paper trail of evidence on behalf of Black women and girls. Dr. Jones is a gifted writer, and her passion lies in changing the criminal justice narrative to one that values Black women. It's her belief that if the narrative is truly to be changed, we must be the authors. We must change the authors, excuse me. In addition to her academic and professional experience, she has over 20 years of life experience in the juvenile and adult criminal justice systems. To sum it all up, Dr. Marilyn Jones is a unique combination which consists of a terminal degree, a plethora of street experience, and a passion to be of service to the community. Thank you for joining us, Dr. Jones. We also have Jessica Nowlan, who is a social entrepreneur and movement leader with a focus on building the resources and structures required to realize liberation. She believes that those most impacted must be at the forefront of decision-making about their own lives and communities, and has spent most of her career developing programming and strategies to support this. Jessica is the previous executive director of Young Women's Freedom Center, or YWFC, where she supported the organization's growth from 5 to 45 staff in 1 to 5 locations and increased the annual budget by over 1,700%. During her tenure at YWFC, Jessica also drafted and launched a Freedom Charter with a base of over 400 formerly incarcerated women, young women, and trans people of all genders. She is driven in her work by her experiences navigating the juvenile justice system as a young person in poverty, houselessness, and intimate partner violence as a single mother. Jessica was the 2019 to 2021 Leading Edge Fellow and is experienced in supporting organizations to strategize, to better serve women and girls at the intersections of violence, poverty, racial justice, incarceration and reentry, and workforce development. As the current president of Reimagine Freedom, Jessica is tasked with holding and nurturing the vision of the Freedom Charter and mobilizing the resources necessary to fuel the work and ensure our movement is successful and sustainable. Welcome, Jessica. Thank you for joining us. And last but not least, we have Ms. Sharon Fennix, who is the Transitions Clinic Network Hotline Coordinator. Her passion for transforming the health system to better meet the needs of individuals returning from incarceration comes from her lived experience of serving 38 years in prison. She is a certified dental technician, licensed ABO optician, certified life coach, and substance use disorder counselor. For several decades, Sharon has worked to support individuals who have been impacted by trauma, domestic violence, substance use, and mental health conditions. Sharon has a passion for working with men and women who have lived experience to help other returning community members. Thank you for joining us, Sharon. So I'm so grateful for you all being here today. And I want to pose my first question to all of you, which is what stood out to you from the study's findings? How do the study findings or narratives within the report resonate with you in your personal and or professional experience? And I will start with you, Ms. Sharon.
Sorry, I was reading a text. Can you read that? Did you hear me?
Sorry, what did you say?
Can you rephrase? Can you state that statement, please?
Yes, what stood out to you from the study's findings? And how do the study findings or narratives resonate with you, either in your personal and or professional experience?
So I like to touch first with my personal experience. After serving a sentence of, of 15 to life, doing 38 years of that term, and coming home trying to learn how to navigate this life outside of prison. One of the things that stood out to me was a lot of my peers, a lot of the girls that I spent, plenty of decades, blood, sweat, and tears. We cried together. We, so forth. Did everything together inside the system. They came out and did not know that they had elements, and chronic illnesses that ultimately two of my friends end up dying. I'd say way too soon, way too soon. And while inside, one of the challenges that I talk to men and women when I go inside and do workshops, I talk to them about medical and I tell them, don't let it be too late. One of the things that you were speaking on that really kind of touched me at the moment and it's nexus to all the things that I can remember is one of the reasons why we don't access medical inside. It's like there's these three components. There's the COs, there's us, there's that medical. And most often, if medical is more connected to the CO system, to the officers rather than to us, most often we will turn a blind eye to going to get the support that we need. And that's one of the stigmas that happens daily within the system. You have to, I tell people out here, we don't have a ducket that we go to. And so one of the things that I would like to really speak on is that when you get out, you are, systematically thinking back to how you had to be here, you had to be there, and so and it's always kind of trained to where you would go, and you had that to do to get to medical, you had that to do to get to the kitchen, you had that to do. Well, with medical system inside and coming out here trying to do that same thing, it took me a while to want to even go to a clinic. I'm like, okay, I don't have a thing with doctors. That inside, I was sterilized and didn't even know I was sterilized. So that was one of the reasons that I didn't know I was sterilized until years later. And the coalition the California Coalition for Women, CWP, they were instrumental in helping me learn a lot about the things that was, illegally done to us. And at the point of my body showing me signs after the surgery, I thought they were taking fibroids away from me. I didn't know they were going to burn the uterine lining of my uterus. And then later on tell me, you have a life sentence, you're not going to have children, so what does it matter? So coming out here and needing to go to the doctor, first thing I thought was they're going to all be the same. Like, I just want to enjoy my life. And so I go in and I tell individuals, you see a sign of anything, and you're right, we do grievances. Sometimes those grievances don't go anywhere. And so at that point, you have to resort to the people out your support network outside. And CCWP was one of those organizations that played a big part of making sure that CDCR did what they needed to do. And so with that being said, that would be one of the things that stuck out to me, is that most often you have to realize, unless you know that you are at a point where you have to be at the doctor to go to the doctor, you're not going to go. Most of them are not going to go for all the things that they had went through while they were inside. Hopefully, as we go about the years and the days, and we continue to abreast people with what they need to know about getting themselves, checked, and getting, exams, current exams, and getting blood tests done, all the different things that give you longevity, until we recognize some of the stigmas that, formerly incarcerated men and women go through while returning to the community. It's going to be something that slips through the crack. And a lot of my friends slip through the crack. And so that's what made me want to get into promoting that we be health conscious and try to do as much as we can to keep what, ever life we have left in our hands, in the grasp of it. It's for me to say this. I'm not asking anyone to follow this opinion, but for the grace of God, there go I. And it definitely is not our saying when we're going to come and go, what day our glass ends. But at this point, I think that we have to be more instrumental in making sure that come out, understand that the medical out here is now ours to choose from, not like inside. Just give me a doctor. And if I choose not to have that doctor, I have to go through changes to change the doctor. And I have to also be, subject to whatever that doctor says is needed, and not giving the information that goes with that.
Wow, there's so much in what you shared, and I really thank you for sharing your personal experience. There's a lot that stood out to me in what you shared, one of which is the experience of sterilization that came up a lot with the women in our study in California. And a lot of that sterilization happened under the guise of hysterectomies, or removing fibroids. And so I mentioned that reproductive health concerns was one of the critical concerns that arose among women, and that it relates directly to the witnessing or direct experience of the neglectful and kind of one size fits all reproductive, I can't even call it care, based on the experiences that they shared. And so I just thank you for uplifting that. I want to go now to Dr. Jones, for if you could also share kind of what stood out to you in the findings, and what resonates with you in your personal and professional experience. And then to Jessica. You're on mute, Dr. Jones.
Sorry, I was gone too.
I saw you too.
I'm a simple person. I look for words that stick out. So the word that stuck out for me is the word listen. It says, what's next? What's next? That whether based in a carceral facility or in the community, to listen. That's what the women want, is someone to listen to them express their pain. And so I want to elaborate on that on a personal and professional level, right? So we are courageous self-advocates, Black women. We will file grievances. We will speak up. The issue, and I did a focus group, and I'm having my own personal life, so this runs across the board with these systems. So it's not, I'm talking about on the streets, okay? So when I talk to youth, their main complaint when their experiences with racism, I never brought up the healthcare system. That's what they brought up. This is in a free world. at the Young Women's Freedom Center. Youth ages 14 to 24. So, and in my own life, when I express what's going on with me, if I act like I have any level of expertise or act like I know what I'm talking about, it's not well received when we advocate. So that's the problem. I would like for you to listen, and that's part of the mental approach too, but I also want results to follow. And that's not what happens in a lot of these doctors' offices, not just in prison. So I don't have the same experience as Sharon is doing a longer time. I was in and out. I went in and out with crack addiction over a period of like 20 years, 15 years, something like that. But, and to this very date, I still have issues with the way I'm treated by healthcare providers. And one mistake I want to say from my own life is admitting that I was a crack addict. And it goes written down in your medical documents for the rest of your life. I don't care whatever you achieve, you get treated differently. There's a stigma attached to that, right? Especially in the medical field. So that's some things. And then also another thing about the listen part, right? As Black women, we have these different stigmas. We're loud, but then they also refer to us as voiceless. So what is it going to be? We can't communicate in any way for ourselves that's acceptable, you know? And like another thing I want to say about the listen part is that, because I'm speaking up for the girls now and the women, you should not have to code switch and ask for help, for medical help, especially if you're in a crisis. So society don't take Black women being in crisis well. You can't move your head, you can't move your hands. You know what I'm saying? You got to be damn near on a job interview to ask for help. So I just want to point that out. So it's not, I understand we're talking about jail, but it also says after incarceration. So I don't know that jail part as much. I was younger. I didn't give a damn. I disassociated my body, myself when I was incarcerated. But the stigma that's attached to it and addiction and racism lingers all the way on through the rest of your life. So, and then they were saying they want to be listened to. So I think that, and I'm gonna let that go. One more thing I want to say is that we got to watch how we training folks, because we grooming a bunch of saviors, you know, and that's how we're treated. It's not whole human beings as a patient on the streets, and our babies too. So I'm just delivering that news. They get mistreated by doctors, the youth.
But what do you, could you explain a little bit what you mean when you say, when you use the term saviors? What does that mean?
So I'm gonna take it to academia. A lot of this language that is used to describe us, the adjectives, are all demeaning, less than. You know what I'm saying?
Mm-hmm.
There's nothing powerful about a lot of the research language, and that's what they learn in school. That's how we're introduced to them. They don't know about our brilliance. They don't know about our ability to make ways out of no way. They just learn about the disparities and like, poor them, I'm going to go help them. They don't know that we have expertise because they train like that. You know what I'm saying? Because I can see both sides of it, because I went all the way through the school system, all the way to the terminal degree. And there's a theme after the higher education that we need help. We got to go help these people. And it doesn't tap into how brilliant we are, you know? That's nothing of the stuff I covered. All the way to the doctorate talks about that. And it's supposed to be social justice. So we got to look out for the little hints of white supremacy that's everywhere. It's subtle, but every time that we got to talk about ourselves, if it has to be less than, and we training people like that, and we don't tell them how beautiful we are, you know? How do you think they're going to address us, like as social workers or doctors or police or whatever? That's the schools train them. That's what I'm saying. And it's the information they have access to. Say, I'm pitiful. I'm not pitiful. And being Black is a wonderful thing. How about that?
Right. Indeed.
How about that?
Indeed. It sounds like it's going back to that strength approach, or
yeah, because I'm not with that.
Strength and not from deficit. Yeah. Yeah.
So that the education that's pushed is from a deficit. based approach.
Mm-hmm.
So the people that's coming out and doing the healthcare, the doctors, because they say they want to be listened to. So that's a problem with hearing, not with my voice, right? So that's the thing.
Mm-hmm.
So what are they? Why is that? That's their training. And it's not on the job training. I'm talking about all the way back to when they were in college. The whole system is rigged to say that we less than. That's how I feel. It's
Thank
not
you for
empowering, it's not
clarifying that.
culturally affirming. It's not empowering to me. You know what I'm saying?
Mm-hmm.
So
Mm-hmm.
it's supposed to be social justice. It's not. It's not equal. The language is not equal.
Yeah.
That's my thing. I got issues with words, and because I didn't.
Words are important and powerful.
Because when I got out of
Words
prison,
mean
when
something.
I started going to college, I had to travel with a dictionary, and I started looking at what everything meant. I'm like, well, damn, this ain't even true. I'm not even voiceless, and I'm not invisible.
Right.
Half the stuff ain't even true. I just want to say that.
Thank you, Dr. Jones. Thank you. And Jessica, what about you? What resonates with you? What stood out for you in the study findings and narratives?
Yeah, thank you so much for doing this report and having me as an advisor. I think, having been in community and, being incarcerated myself, but being in community with so many incarcerated, formerly incarcerated women over the past several years, I think that the findings resonated as what folks talk about to each other when you're in space. And so I think having actual findings in a research report is really important, because we know that people's voices are dismissed when these things are said. One of the things that's on my heart in reading these findings, I'm a co-founder of Sister Warriors Freedom Coalition. There's over 1,000 members across the state and in California of formerly incarcerated women, and as well as inside members. And some of the work that we're doing right now is to stop the sexual abuse of incarcerated women in prisons and in the juvenile halls. And I just, it's really on my heart, because of course there's a distrust. And as Sharon pointed out, when you're filing a grievance, you're filing a grievance to the people that are also creating harm to you. And so I just want to lift up how voiceless and how that resonated. But the other piece that really resonated with me is folks advocating for each other, and I think I'll talk about the Freedom Charter a little bit more, but just being at the center at the Young Women's Freedom Center for so long, and with Sister Warriors, that the communities that women make with each other and advocate for each other. If you read the Freedom Charter on the Sister Warriors website, you'll see that health is almost in, I think, 5 of the charters, right? Because so I just want to lift that up, and how important that is, people advocating for each other. So, and connecting with supportive organizations. So those are things that stood out to me.
And I'm going to come back to you with more about the Sister Warriors. But I want to loop back with you, Dr. Jones, to dig more into something you mentioned. You mentioned the Araminta approach, and I wanted to ask, there's been a lot, increasingly more coming out about gender responsive strategies and practices for working with incarcerated and formerly incarcerated women. Since the number of women in state and federal prisons began to skyrocket in the 1980s, and just for definition's sake, gender responsiveness is recognizing and accounting for the important differences between men and women in psychological development and socialization and culture, exposure to trauma and life experiences. But there are also critiques about what gender responsiveness is versus what it should be when it comes to Black women. And so wonder what are your insights on this gap, and thinking about your own research, the area mentor approach and other research you've conducted. Can you discuss what a more culturally affirming approach for working with Black women involved in the criminal legal system would consider and entail, especially as it relates to health?
That's a long question. That is a long question. So let's get to the beginning. What was the first part?
What are your insights on the gaps between what gender responsiveness is and what it should be when it comes to Black women? What's a culturally affirming approach for working with Black women in the criminal legal system?
I'm gonna take a Black feminist approach, and I'm gonna say what it should be, because it's not a spinoff. I don't need to do a spinoff. I'm gonna go on. You know what I'm saying? Not to be funny, but so I don't really want to critique it to the point to where I'm gonna tell you like this. I'm from San Francisco, California, and Black women represent 5.7% of the general female population, and we represent 50% of the counties here, right? This is a liberal city that has a plethora of gender responsive services. I think I take my hats off to the women that created it, and I believe they did some changes on the inside. They got some rules changed. However, to be honest, I don't think it transferred to the streets. It hit Black women. I don't think it's necessary to we spend any time critiquing something that hasn't worked. Right? I think the body count, to me, and so I'm feeling weird because I know everybody, you have to quote those words to get funded. Right? So that's what at this point it's become buzzwords. You know what I'm saying? When it comes to us. So I think that although the words I mentioned, there are some words in there that they're using now. I think it hasn't evolved. It's been sounding quite the same for some decades, right? So that's one thing I think about it. So I think that when we're doing social change, things are supposed to evolve. And also, if we see that something's not working for one population, right? You're supposed to figure out how. That would be our job, though, because we didn't create gender responsiveness, by the way. So that's the critique right there. If we're the hardest hit population, and that didn't come from us. So I'm not knocking whoever created it or whatever, but and everybody talks about it behind closed doors too. So I'm not just the only one. We are aware that Black women are still, it has not improved for us. So can we acknowledge that we're still in jail, right? And so I want to say that for me, it wasn't about critiquing gender responsiveness. This makes me sad. It ain't about that. It's been going on since the crack epidemic. It's almost 40 years. I've been sad about the same issue. So I didn't even know nothing about gender responsiveness when I was sad about it. When I got hooked on crack at the age of 20, I'm almost 60. And we still talking about a colorblind approach. And they target, and so to me, it's colorblind. Okay?
I see.
That's the
okay. And so do you see the area mentor approach as a fill-in in this gap, or a more culturally affirming approach, or how does that fit in? And tell us about it.
Okay. Well, first of all, there's not a gap, there's a gaping hole in research when it comes to the importance of Black women in the criminal justice research. We're not there. And when we are there, our bodies are there, but our input and our expertise and our souls and our whole swag is missing, and we put in a lot of years to not be counted like that. That's what I'm gonna say. So it's not a gap. It's just not happening. And I wanna say that was not created for us with us in mind, gender responsiveness. It wasn't. So, and I know that for a fact, okay? And so the thing is, the airment approach, I created it because we need something. We need something for us, right? And I was thinking like, okay, what is designed to give people more of understanding of the complexities involved, right? The general responsible, they're on the money. They're saying the right words. We need to be culturally responsive. The airmental approach spell out what that means. So if you're talking about trauma informed, for me, you may not know what traumatizing me. The airmental approach can help you around that. And then it's not a monolith approach, but we do have commonalities. And it also addresses the burden of strength that is placed upon Black women and by the medical system. They do that too, that we are stronger than everybody else. And we have some degree encompassed that. And then also says 30 things about the strong Black woman schema, which I use in my framework that I see that can lead to poorer health outcomes. You know what I'm saying? But also I see this somewhere to get a better understanding. So I utilized it so we could start coming up with something for us. Now, I wouldn't say the airmantic approach is all answers, right? But what I will say, it's a step in the other direction, right? In the recovery or whatever, they had a cliche doing the same thing, expecting different results. Okay, that's what gender responsive is for me right now. I'm not trying to improve it. I'm doing something else. Because if it wasn't created for me, why am I trying to improve it? Let them do their thing. They've been writing that for decades. It's, I think that as researchers, so their mental approach recognizes our value and respects our minds and works from there. Not trying to impose what, like needs-based. I do a desire-based. Remember, that's what I talked about, desires versus needs. Because everybody, to me, we're not different type of human beings as formerly incarcerated women. We all need to eat, sleep, and be safe, and be healthy. Everybody is human beings. Now, we might run into more problems with that due to trauma, but we can't just be saying trauma-informed and saying all these words and not knowing what it means to us, and we the hardest hit. We are who this system was created for, and we're not benefiting. So how does that doesn't sound logical to me, to keep relying on something or trying to fix something that may not be for us. That might be for policy, changing policies and getting things for all women, you know what I'm saying? But that's not for Black women,
Yeah.
And I think as researchers, we have the responsibility to see. So if you're researchers, look at the data, and that doesn't mean just on paper. You got to acknowledge the body count. So I don't put more weight on paper than these body counts, because that's what they count in the penitentiary. It's count time. That's how this whole thing revolves around count time. I don't know if you know about count time, but they count your bodies 4 times a day. So I don't know why I'm saying that, but it's like we got to count. The count is not adding up to me. The count doesn't match these evidence-based practices. So I'm assuming that I'm not included. Okay, because if I'm 10 times more likely to be in jail, and I'm only 5% of the population, right? And everybody's pushing that agenda. What is the logical thing for any human being trying to survive and save their people to do? Do something else. Do something that's for us and not be ashamed to do it. And I know it's not trendy, because this field is very trendy. So that's what gender responsive is. It's trendy. Does it help? I don't know. But does it give you some money if you want to pay for, get some funding? Yes, you have to say that.
And I want to direct folks to the link to the airmental approach that was dropped in the chat to read more about the approach that Dr. Jones developed from her research that she's referring to. And I can't believe it's 10 minutes before the hour right now. So I want to come back to you, Ms. Sharon.
One more thing. You asked me what does culturally affirming look like. Culturally affirming acknowledges the perks of all this melanin. Okay? It's not a bad thing. It tells us, and that's where I was raised in San Francisco, and I went to all Black schools. So the Panthers, from the kindergarten to 3rd grade, they brainwashed me. But they taught us about the perks. And we're going to have to teach each other about it, because it's a beautiful thing. And I just want to say that, that's culturally affirming.
Thank you for adding that.
Me. It feels good to me.
Mm-hmm.
Not comfortable to you.
Right. That's important. Thank you for adding that. I wanted to ask you really quickly, Miss Sharon. So the women in the study, several mentioned the Transitions Clinic Network as an important organization in meeting their healthcare needs. Mentioned that the prevalence of chronic health conditions among formerly incarcerated people generally is high, but especially aging Black women, and which makes healthcare access critically important. So I'm wondering if you can tell us about the Transitions Clinic Network and your role, and what makes it a promising model to support the health needs of women transitioning from confinement to community.
So the Transition Clinic Network's model, it primarily provides immediate patient-centered primary care, medical, mental health, dental to returning community members. And one of the essential points about the model also is that they hire CHWs, which are community healthcare workers, who are men and women with lived experience, trained to help and support the needs of the men and women coming out. However, they have lived an incarcerated life. So that history makes them, at that point, the specialist, the professor in that area. When I got out and went to Southeast Medical in San Francisco, I think what I can say that prompted me to want to work with the Transition Clinic Network is that the people that come out and talk with you and walk you through things about medical are your peers, are the people that have done time like you have, understand the language, understand what you've been through, know how to get that response from you. And so that's really important, is that, I can come out and that person that has the doctrine can, tell me about my illness, and some point tell it to me through the medical terms, what's written, but there's no passion and no compassion, no empathy, the way that it's said at times. I think that what I loved about the Southeast Clinic is that that's not what happens at that clinic. You get out and that peer comes out and he says, look, first I want to tell you, I understand what you're going through. Most often I'm gonna look at him and say, do you really? Who are you to tell me you understand what I'm going through? What do you mean? But then it's followed with, I was formerly incarcerated. And the model to hiring men and women with lived experience, those of us that have trauma, went through the things, because I always want to say this, the trauma of going in does not stop. Go in, it continues, and it continues, and it continues, and it continues. And then when you get out, you're trying to put all those pieces together, you're trying to compartmentalize all those different areas of what you've been through, and then guard yourself. As Dr. Jones was saying, sometimes you have to guard those things. Well, at this point, that model that they have of men and women, actually, like, you're not hired unless in certain other areas, yes, you're hired, but for community healthcare workers, and most often, they're trying to hire people who have lived experience to make all of this much more comfortability, to make it comfortable, to make it to a point where you can understand what you're going through and get that person behind you to get you to think towards getting your needs supported. Because that's one of the first things that has to happen. We're going to be on guard. We're going to come out feeling like, I love that our mental approach you're talking about, the things that has to be recognized. We're going to have to, that word that she said, you have to listen. You have to listen, because we come from from a plethora of where you're not listening to us. I'm just a ducat, I'm a number, then going back where you're coming from. Next number, next ducat. And it's a melting pot. We're all in this together. Coming out and having someone who's trained to help you or continuously being trained to meet your needs. That person has been formerly incarcerated. It's a beautiful tool to have. And Transition Clinic Network is what I do as a hotline coordinator is I take calls from all the prisons in the state of California. And when they call me, I immediately let them know, my name is Sharon Fennix. I'm a Transition Clinic Network coordinator. I was formerly incarcerated. How can I help? And right away, I can hear in their voices that they forget what they want to say at first. They get to telling me, "Oh, you were," it's like it's an immediate connection, and then I can tell them the things that's needed. I try not to sugarcoat anything about what's on the south side or the other side of the fence, and I stress to them, please make sure you sign up for Medi-Cal before you come out, because out here you're going to need that. You're going to need that medical asset. And so mental health, MAT, the Suboxone program, we do all those different areas. And of course, because we've had this experience, I'm going to tell them where they can go to get food. I'm going to tell them where they can go to get clothes. I'm going to tell them where they can get transportation. I'm going to tell them where they can get housing. That's not what the Transition Clinic does. We don't have those resources, but we do have them because we have people with lived experience. So we're going to share the word and the work. And so that's why I feel that the organization that I'm working for, this Transition Clinic Network, is a really good organization. Whereas I have a bunch of peers that lived in this field box I did. They know how to support the person coming out.
Thank you so much. That speaks directly to the desires that the women in the study express about what they need. So thank you for lifting that work up. We are almost out of time, so I just want to do a quick round. If you could just name maybe one call to action of what transformations need to happen at the systems level within the criminal legal system or the healthcare system to ensure that Black women can access resources and services to support their health and wellness, to help them thrive after incarceration. It's one call to action that needs to happen for that to happen. I'm
gonna get myself out the way while it's in my head. Right away, I say conservatorship. A couple of years back, we had a conservatorship when they first thought about what doctors were not doing inside the prison in the system. Outside here, we needed as well. Inside and outside, we need a conservatorship. We need people that are paying attention to what we're saying. And we need more people who have had this experience, not just, because you have the education. We need more people who have consistently worked with this and have the experience to be heard. And that voice, and while we're giving you what's needed, that should be implemented. Just like, you were saying, Dr. Jones, that voice, just don't say, listen to the problem and don't have the solution. You need to start listening to the problem and put down that solution with action. Period. Enough. We don't have a conservatorship. We don't have people that really are banding together. It's like I agree with Dr. Jones when they say it's all, you have to use these keywords to get the money. No, let's not worry so much about the money. Let's worry about changing the system.
Amen.
We are at the hour. Quick calls to action. Dr. Jones, Jessica, what needs to happen?
I'm going to call to action on the research people. So there's a gap in research and people can't get the piggyback ride they need to get us the help that we need because the research forms programs. I'm thinking that instead, we have a lot of research what's the research where you do interventions and test, does it work? That's the research we need. We need a body of research, a body of literature that explains what's effective for us. We not only what's wrong, but what works for us. And that's the color. And I'm in the process, I'm gonna put this out there, of creating model programs, and I need support. So if anybody's on this call, you can go to my website. If you wanna link up and support me, I have 2 programs. One is intergenerational with Black women between the ages of 16 to 24 and 50 plus. It's called The Missing Link. It's great. I can't even explain it right now. It's beautiful. And we're seeing very promising results, and there should be things that could be done on a national level. We need to figure out what works for us. It's not hopeless, y'all. That's what I want to say too. It's not hopeless. We don't have to accept this, and we ain't got to sit down for it. We can change it. And I'm also going to say, Black women, get out in the lead in this field. It's okay. It's okay to say stuff different. Everybody not going to be comfortable with change. Change is not comfortable. You know what I'm saying? So we got to be courageous. I know you're looking out for your careers, but it's people's lives on the line. So we got to go ahead and be courageous, and God gonna provide for us anyway. That's what I want to say.
Indeed. Indeed. Thank you, Dr. Jones. Any calls to action for you, Jessica?
Yeah, I would just say, for directly impacted women, you can join Sister Warriors at sisterwarriors.org. And the what we do is spend time together figuring out which policy and systems change we're going to advocate for. And if you're an ally, you can also support the work of Sister Warriors by joining at Sister Warriors Action Fund, which supports that work, and become an ally member. And I think that just one last thing I want to say is we need more ways for incarcerated women to be able to reach us that is not tampered with, and so that we could better support them while they're inside to make sure they're safe.
Awesome. Thank you all so much for joining this panel today. I learned so much from y'all, and for everyone who is in attendance. This is being recorded and will be posted on our social medias. Once you leave this meeting today or this panel today, you'll receive a post-survey event. We would love to get your feedback on today's event. You'll also receive it via email. Check out the links in the chat. Thank you so much. And until next time.